Okay, well, thank you very much. Good afternoon from Singapore. Good evening, good morning, wherever you are on planet Earth. Welcome to this month's episode of Conversations in Planetary Health, entitled Green Vision, Eye Care in the Era of Planetary Health. I'm Dr. Renzo Ginto, Associate Professor and Lead of the Planetary Health Program of the SingHealth Duke-NUS Global Health Institute here at the Duke-NUS Medical School, National University of Singapore. And again, I welcome you all to this important and surely insightful and informative and hopefully inspiring conversation about the future of eye care practice in this era of climate change and many other planetary threats. This conversation is very timely because we are having the UN climate negotiations happening as we speak in Brazil. You might have seen in the news COP30. You know, all the negotiators, all the countries are there. Unfortunately, we cannot be there, but that's why we're having this conversation with our practitioners, our professionals from the eye care sector. And, you know, the title, Green Vision, is very, important. And I wish that our negotiators, our political leaders will also have a green vision for the future of our planet and its people. And while they are talking in Brazil, now it's the time for our colleagues from the eye care sector to also showcase what they are doing, what can be done at the level of eye care in the healthcare institutions, in clinics, etc. So that's what you're going to hear today. Because, as you may have encountered, around 5% of the global greenhouse gas emissions attributable to the global health sector. And actually, here in Singapore, there was a recent report published just a few weeks ago, and the estimate was that around 7% of the country's emissions also attributable to the healthcare system. And so, you know, doctors, health professionals, optometrists, you know, all of healthcare can play an important role. So again, thank you very much for being here. Special thanks to our partner for this specific episode, the Singapore National Eye Center, who is our neighbor here in Duke-NUS at the SGH campus. And of course, special thanks to Muskaan and to Lingyan for not only leading and moderating this session, but really thinking about what we are going to discuss in the next hour and a half. So thank you again, and I pass the mic to Muskaan and Lingyan.
Lingyan, yeah.
Okay, thank you, Dr. Renzo. Wishing a great day to our international speakers and audience tuning in from across the globe. Thank you for taking precious time to attend this series of eye care in the era of planetary health. So as Dr. Renzo had mentioned, ophthalmology is actually one of the world's highest volume medical specialties that actually provides life-changing care, but also generates significant environmental impacts through all the energy-intensive facilities, as well as medical waste and high patient load. So as the health system actually moves towards the net zero goals, sustainable eye care offers a powerful opportunity to lead the transformation towards greener and more sustainable healthcare. So in today's session, we would actually like to put eye care within the broader planetary health agenda, which aims to inspire cross-sectional collaboration and chart a pathway through a resilient, low-carbon and patient-centered ophthalmology in the era of climate change. So we have actually 4 speakers from international speakers from India, UK, Australia, and Singapore, who share case studies and innovations in a sequence of frugal system designs to clinician-led behavioral shifts, institutional level considerations. I'm Lingyan, your co-moderator for today. I'm an optometrist in Singapore National Eye Center, or SNEC, and a member of SNEC's Global Eye Health. My privilege as a moderator today is largely contributed by self-interest and motivation for continuity post-planetary health module as part of SDGHI's graduate cert course, which Dr. Renzo conducted. So I hope to be able to share that privilege and motivation with the rest of you attending today, regardless of your profession. So in today's sharing, the sequence of events will start by my introduction of each speaker before their sharing. After all the speakers have spoken, we'll then wrap up with a 30-minute panel discussion where you can get your questions answered. So please feel free to type your questions in the Q&A as the sharing is ongoing. Muskaan, do you want to add anything to share about yourself in the meantime?
Yes. Hi, everyone. I'm Muskaan Khepla. I am the research associate at the Singhal Duke-NUS Global Health Institute. I am really excited for all the presentations today by our speakers. I'm just really looking forward to learning from you all, especially about this really important topic in the era of planetary health and climate change. Over to you, Ling.
Okay, without further ado, thank you, Muskaan. We'll start off with our first speaker, Dr. Venkatesh. He's a chef medical officer at Aravind Hospital in India and a visionary ophthalmologist, revolutionizing eye care through environmental sustainability. His groundbreaking research reveals that UK cataract surgeries produce 20 times more greenhouse gases than Indian procedures. Dr. Venkatesh has transformed waste management in ophthalmic care, pioneering reduce, reuse, recycle principles that dramatically lower carbon footprints while maintaining excellent patient outcomes. As an advocate on the IAPB, or the International Agency for Prevention of Blindness, Climate Action Working Group, and Eye Sustain Advisory Board on the American Society of Cataract and Refractive Surgeons, he champions Aravind's low-carbon model globally. Dr. Venkatesh proves that exceptional healthcare and environmental responsibility go hand in hand. He'll be sharing about the Aravind model of low-carbon eye care, race to zero with frugal innovations, showing Aravind's high-volume, resource-efficient model for sustainable ophthalmology. Dr. Venkatesh, please.
Thank you. Thank you, the Singh Health and the National University of Singapore team for organizing this very important symposium on climate change and how each one of us can be a part of taking care of this change. So I work in Aravind Eye Care System for more than 30 years, and I'm a part of a big system. For people who may not be aware of Aravind, so Aravind started 50 years back. So we are celebrating our 50th Jubilee now with 11 beds. And now we have 8 tertiary care centers, 7 secondary care centers, 8 community eye clinics, and more importantly, 118 vision centers across Tamil Nadu and Pondicherry. And on any given day, we see close to 20,000 outpatients, and we do close to 2,500 surgeries. Most of it is cataract, a lot of other specialty surgeries, lasers and injections. We do a lot of outreach activities where we go as a team to the field, screen, and then bring patients only for surgery and treatment. And being a teaching and a training center, we train a lot of people, both in ophthalmology and also all the allied ophthalmic personnel training. So when it comes to sustainability and resilience, especially in healthcare, I'm sure we all know that there are so many things involved. When we are giving a healthcare, electricity, capital goods, there are a lot of things which are kind of disposable and single-use materials these days, especially lighting and ventilation in our hospitals and operating rooms, reusable supplies and sterilizations. And more importantly, we have to kind of come across all of these contracts. We have to look at travel of staff and patients, the food services which is available, the technology development and suppliers. And more importantly, we are also governed by a lot of policies and regulations. We need to constantly train people and take care of the local habits. So what we do, at least back at home, is many of the time we see it as a systems issue. And we take care of it as a system so that we are friendly to the patients. So it's a kind of a patient-centered organization. So I'm going to share in the next 12, 13 minutes about what we really do to kind of reduce the carbon footprint in our eye care. So in general, we can put this into these 2 buckets. Whenever we call about reducing carbon footprint, the general things, which most of us try to do, at least in the new facilities and new hospital buildings, even at Aravind, all the new hospital buildings which have been done in the last 20 years after Pondicherry have been green building, have all energy efficient appliances and gadgets. Even the old ones we had in the older hospitals, we have changed to new energy efficient appliances, looking at alternate source of energy, especially solar and wind energy, minimizing travel and transport. This is one thing which I will focus a lot in the future slides. And then looking at really, consumable procurement of whatever we need. We focus a lot of time and energy in maintaining equipment so that we give a long life and we prevent breakdown of equipments. And of course, on water and food management to some extent. So this is to show you just how much of thing we have spent over solar energy across all our facilities. And if you see, the maximum is in Pondicherry, where I come from. We have a 540 kilowatt of solar energy, which can take care of almost 60 to 65% of our energy needs on a daily basis. We are still working on making it 100%. So whatever energy we buy is also clean energy from outside. So this is the Pondicherry facility you see with all those solar panels, which are taking care of our needs. So almost 65% of the total energy is taken care by solar power. And also we have done a lot of things inside over a period, changing to all new equipments which are energy efficient, which again saves a lot of energy. And we have spent a lot of efforts and money into recycling water, especially we have something called the DWATS, the decentralized wastewater treatment plant, which almost treats 90% of water, which is again used in our urinals for flushing toilets and also for taking care of our beautiful gardens. And almost 3 million liters of water is recycled every single day. So these are some of the general things now we practice across our system. But the most important thing, I think the focus should be on how you design your services to your patients so that you really take the care to the patients. So this is where most of my talk will focus on how we constantly think of reducing, reusing very carefully, and also recycling optimally. So we try to reduce a lot of things, especially on the travel of our patients. So we try to close the loop at a single visit. What do I mean by that? Like if somebody needs an investigation or even a treatment, we try to finish on the same day. For example, somebody who needs a laser iridotomy for a narrow angle, if he is prepared, we would finish on the same day. Or maybe a fundus fluorescein angiography investigation for a diabetic retinopathy, or maybe even a OCT or something like that, we would do it on the same day. So we would kind of avoid another appointment and a travel to them. And of course, a lot of energy has been put into EMR use now. There is a very rationalized use of consumables. And we have kind of standardized all the procedures, SOPs, in the operating room, in the outpatients. It's more like an assembly line where efficiently every equipment is used. And we carefully reuse and multi-use several things in the OPD and in the operating room. I'll touch upon a little bit later. And of course, we also do a lot of recycling. We all understand that when you look at carbon footprint, in any healthcare, especially in eye care, you have a lot of footprint in accessing, in diagnosing and advising, in treatment, and of course, follow-up of chronic conditions. But there are several times you find a lot of leakages in the system where people have to come multiple times to the facility. We have tried to really kind of close those leaking points so that the patient would really come for the care, and then they are even followed up in our secondary and primary care centers wherever the need is. So if you see, this would be the workflow or a work process in any facility. After registration, you do several investigations and you do treatment, and then you do optical or medical services. But in Aravind, there is one person doing one task. And because of that, they are really skilled to do that job, and the quality is really good. And optimally, the equipment is utilized, either being a OCT or a HFA machine or a microscope is optimally used for the 8 to 10 hours of a day when it is being used. So I want to show you beyond the base hospital how our vision centers run. So these are centers which are in 500, 600 square feet facility in a semi-urban or a rural area. We have 118 centers. Pondicherry runs 19 centers. We have 2 people who run that facility. One of the staff is a technician who does registration, who does blood pressure, blood sugar. She is capable of taking a fundus image, and then we have an offline AI now which can assess the image immediately at the doorstep, and then this is incorporated into the electronic medical record as you see. And then we have another person who is an optometrist who is well trained to do refraction, check intraocular pressure, do a basic slit lamp examination, and then feed all this into the electronic medical record. And every patient gets a telemedicine through a doctor who is a senior resident from the base hospital. So each doctor, they take care of 5 to 6 centers. The whole day they do only that, and they have a rotational posting for that. And wherever there is a need, we would dilate and then take a fundus image. And then the doctor would see all that on the EMR, and then the patient gets a prescription or glasses. People who need specialized care are referred to the base hospital. So who really need specialized care is only less than 10%, I would say. So 90% of the problem is taken care in the rural area, and comprehensive care happens. So we have centers like what you see in this map across Tamil Nadu and Pondicherry. And what we realized was almost 95% of care is completed at Vision Center, so that they don't have to travel to any other centers far away from their own home or their village. So even during COVID time, what we realized that the centers were really doing very well, and many of these centers were almost doing the same volume as they do on a normal day pre-COVID. So this data also we looked at very carefully during COVID-19. Now we all remember what happened in the 2020 and 21. So if you see the patients coming back to the base hospital during the peak wave 1 and 2 were only 40 or 50% to the tertiary care centers. Whereas if you see to the primary care centers, they were almost 80% of people going. So we realized that the impact of Vision Center is beyond what we really imagine. So even during calamities like this, they do very well. And through these models, we have created very interesting plan during COVID time. Like a Vision Center patient would come 3 times for a surgery, but now we made it 1 time, and we call it a single visit cataract surgery. All the pre-op is done in Vision Center, the post-ops is done in Vision Center, and by which we found there was a significant reduction of carbon footprint. This is a calculation we did in 2024 by doing the single visit, so that the pre-op in Vision Center, post-op in Vision Center, we could significantly reduce 393 tons of carbon emissions, because the travel, which is the most related carbon footprint we see in most of the systems. Same way, many of our paying patients, we normally did not review them in the Vision Center, but during COVID, we advised them to go to the Vision Center for review, and they were also happy to do that. And this is a data which we see almost like 50% of our paying and free direct patients went back to the Vision Centers for their 1-day review, and by which we were able to reduce nearly 1,237 tons of carbon emission. So the other travel area we really focus is of our own team, the doctors and paramedic. People who have visited this facility would know we have an inbuilt quarters where people just have to walk to the hospital, and more than 90% of people stay within the campus in all our Arvind eye care system hospitals. So we also looked at, now whenever you are looking at people and planet, you make profit, now either for you or for the provider. So this particular work we recently published, where the travel and financial burden we looked at for people who come back to the Vision Center or to the base hospital, and the burden was significantly less for the people who are going to the Vision Center than people coming to the base hospital. So this is a work where we looked at base hospital alone, Vision Center alone, and then a combination of both. And we found that the total wait time had reduced, the transportation time has reduced, and also they could save a lot of money, not only on transport, but also when people come here, they lose a wage for the whole day, and the caregiver also loses wages, because they are mostly, daily laborers who are dependent on the daily wages. So they can also save money, which would help them. So this is one area finally I would focus, but this is where my main talk would be on your surgical treatment and how there is a large carbon footprint because of the high volume cataract surgery, which most centers do. And cataract surgery, we all know there is high energy consumption. There are a lot of capital equipments, a lot of consumables. There is a complex waste generated, plastic, paper, bottles, biomedical waste, and also a lot of water being used for RO and also sterilization. So over a period of time, we have brought a lot of efficiency in the way we do. We do something called the two-table system, where each surgeon has got 2 tables and 2 nurses to assist. And then instead of 3, 4, they would have 6 to 8 surgical sets. And any average surgeon would comfortably do 6 or 8 surgeries in an hour. I'm talking about either a small incision or a phacoemulsification. And some people can even comfortably do 8 to 10 surgeries an hour. So this is the productivity of an average Aravind eye surgeon, which is close to 2,000 cataract surgeries every year. And when you compare it to the national average, it is 4 or 5 times higher in any surgeon who operates anterior segment or cataract surgery at Aravind. So a lot of focus goes on making sure your protocols are stringently followed. There are a lot of SOPs in place. Sharing of supplies happens carefully. There is a minimal use of single-use instruments. A lot of reuse happens with flash autoclaving in between surgeries, and waste segregation. Also, we focus on the generation point so that you really follow these 3 R's. So this is something about how we carefully reuse, and especially our flash autoclave, because there's a lot of debate going on whether we can flash in between or should we go for a full cycle autoclave. So this study we published a couple of years back, looking at the microbiological safety profile of reusing the surgical instruments between the surgeries when you do this flash autoclave or the fast autoclave. So this was a prospective cohort study looking at bacterial and fungal cultures. There were more than 3,000 samples observed for 7 days. There were no bacterial or fungal growth noted on culture of any of the samples. So we looked at these are things which goes to the flash autoclave or things we use till the end of the day, like the saline bottle, which we use continuously, the handpiece, which we don't change for each patient. So the swabs were taken from here, and then we looked at the bacterial and fungal growth for almost 7 days, and there were no growth and there were no infections during that period, where we looked at 3,000 plus samples. This is a landmark work, which we did some time back. The same protocols, whatever we follow, is published here. And we looked at 2 million consecutive cataract surgeries with MOXIE, 1 million without MOXIE. There was a significant reduction of endophthalmitis when you use intracameral moxifloxacin and also when you follow these strict protocols. But basically, now what we see is our endophthalmitis, which used to be 8 in 10,000, came down to 2 in 10,000. And we have 2 endophthalmitis in 10,000 cataract surgeries for almost a decade now, since we started using intracameral moxifloxacin. So during COVID time, we were forced to do the Western style. That means there was only one patient in the room. Everything was clean, mop. You changed gloves for every patient. You kept changing everything. And then we wanted to compare what happened just before COVID, when we did the normal protocols, when the patients were not gowned, when the surgical counts, no gloves, we just used an antiseptic, when the OR floors were not cleaned in between every case. And then there were a couple of patients in the room, like the 2-table system, versus each patient was getting a gown. The glove was changed for every patient. The floors and counters were cleaned between patients. And only one patient at a time underwent preparation and surgery. We compared these two. And then the result was, as expected, there was no difference in the endophthalmitis or any other complications we encountered between these two groups when we followed the strict protocols as per the standards and as per what the Aravind normally does.
All right, Dr. Venkatesh, well, close the time. Could you wrap up in less than a minute, please? Thank you very much.
Okay. So this is something, which I would like to focus finally before I finish. It's so important that you'll have to really segregate waste at source. So this is a complex slide, but if you see the green ones are almost 85%, and the other part of the waste is only 15%, no, which you autoclave at the end of the day, or you put it for biomedical waste. It's only 15%. So if you can segregate waste, you can save a lot of money, and we have proven that your waste which is generated is almost 10 times less than what happens in the Western world. And these are studies which we have published over a period of time to show that the carbon footprint of phaco when compared to US and UK is 20 times higher than Arvin, whereas our infection rates are similar or lower, following all these protocols which we stringently follow. And again, I thank the team for giving me this opportunity, and I'll end my presentation here. Thank you.
Thank you, Dr. Venkatesh, so much for sharing innovative frugal system on how we can rethink the way we can carry out our routine work processes. Our next speaker, Dr. Yee Ling Wong, is a corneal fellow at the Royal Victorian Eye and Ear Hospital in Melbourne. She completed her ophthalmology training in the UK at Manchester Royal Eye Hospital, where she gained experience across a broad range of subspecialties. During her time in Manchester, she was actively involved in clinical research and education, with interests in sustainable practices in ophthalmology and innovations in eye care. Her passion for sustainability, focusing on climate change specific to eye care, can be clearly shown in a couple of papers she's written over the years. Dr. Wong will be sharing on the topic Sustainable Ophthalmology, Meeting Rising Demand While Protecting Patients and the Planet, where she'll cover innovative ways to achieve this goal. Dr. Wong, please.
Hi, thank you so much for inviting me to speak today, Dr. Venkat. Your talk was really good, and I think there's a really good link on our talks as well. So my topic will be focusing on high-value care approach in sustaining ophthalmology, more in terms of looking forward in the longer term. So a little bit about me. I'm currently a corneal fellow. 3 months into my fellowship at the Royal Victorian Eye and Ear Hospital in Melbourne, I completed my ophthalmology training back in Manchester in the United Kingdom. And midway through my ophthalmology training, I actually published a paper called Ophthalmology Going Greener. This was back in 2021. And in this paper, we actually highlighted the amount of the massive amount of cataract waste we produce in our UK centre. And also we highlighted the good practices of Aravind's high-volume cataract surgery approach in our paper, and comparing their carbon as with the Western world, such as the UK and America. And as a result, I got invited to be part of iSustain, which is a global coalition to make ophthalmology more green. And from there, I had multiple opportunities to publish more papers, including impacts of climate change on ocular health, book chapter on climate change and disability, and more recently, earlier this year, a paper on sustaining ophthalmic practices for the future, utilizing high-value care approach, which is what we're going to talk about today. So when we mention about sustainability, we often focus on carbon and cost. However, if we want to make a difference in terms of change, protocol change, policy change, governmental change, we have to prove that this change is going to impact our patients in a positive way in terms of quality of life and their ocular condition. So in our paper, we highlighted a couple of areas that can potentially change in the longer term, utilizing evidence-based medicine. So the first thing we mentioned about was on immediately sequential bilateral cataract surgery. And we know that this practice is evidence-based. However, it's not widely implemented everywhere. And we found that literature suggests that the main reasons being that clinicians are very worried about the incidence of bilateral endophthalmitis, the risk of refractive surprise, because we can't really compare the refractive aim post-op, and also the risk that of potential medical legal implications. In America, it is more to do with the Medicare system, where clinicians are only reimbursed 50% for the second eye if ISBCS was done for the patient. And Although various papers have been published, including a large UK data involving over 3,000 patients, as well as a Canadian paper involving over 400 patients, and there's no incidence of endophthalmitis following ISBCS. And it is true that in literature, there are case reports, 6 of them, suggesting the risk of bilateral endophthalmitis following ISBCS. However, it is important to also note that none of these cases, they follow the guidance as set out by the International Society of Bilateral Cataract Surgery. And we know that practically speaking, if we did both eyes at the same time instead of one eye at a time, it would save a lot of carbon and cost and improve productivity, even despite having to use or to treat both eyes as 2 separate procedures while patient is in the theater room. Utilizing a new set of equipments for each eye, utilizing a new phacoprobe for each eye, and redraping the patient, having a different scrub nurse to reduce the endophthalmitis risk, we would still be able to halve the carbon on the basis that patients come to hospital once for their procedure, once for their pre-operative assessment, and once for their post-operative assessment instead of twice. And in terms of efficiency, the productivity would also improve because the patients doesn't have to be wheeled in and out of theater. We do both eyes at the same time. It means more numbers of cataract that can be done in the same session per day. And an interesting survey data published by Exeter suggests that quite a lot of patients, 72% of the patients, are actually quite willing to undergo ISBCS if given the choice. So following that paper, the UK Royal College of Ophthalmologists, they actually heard. So 2 months ago, they published a guidance on sustainable cataract surgery, actually recommending the use of ISBCS for routine cases, which is a good start because we then will have more data on the safety and efficacy of carbon and cost, and more clinicians who would be more willing to implement ISBCS in their practices. The second thing that we discussed about in our paper was to combine cataract surgery with minimally invasive glaucoma device. An ophthalmologist innovator based in America mentioned once in his interview that any patients who present with for cataract surgery who has mild to moderate glaucoma should be offered a minimally invasive glaucoma device. And his reasoning is that it actually is a safe procedure. Increasing the safety profile is very good, and that we would reduce the risk of the patients having progressive glaucoma, hence reduce need for trab and tube in the future. However, from the sustainable perspective, in terms of cost and carbon, he's not actually wrong, because if we are already intraocular, we are doing a cataract surgery, this additional 15 to 20 minutes procedure can potentially reduce a lifetime need for drops. For example, if a patient comes in 70-year-old having cataract surgery, you put a mixed device in their eye, and potentially they don't need 1 or 2 drops for the next 20, 30 years of their lifetime. This means less plastics packaging associated with eye drops, and also less glaucoma drop side effects, which means more dry eye drops and its associated plastics packaging. And also, it doesn't just improve from the environmental perspective, improve the patient's quality of life as well as compliance. We know is a huge issue that patients don't take their glaucoma drops, hence the progressive glaucoma. So as for patients who are not quite ready for cataract surgery, we still think that SLT should be recommended for a lot of people with open angles and also for ocular hypertensive because of the same reason. We reduce the need for lifelong drops and drops, plastics, packaging, etc. And also it's shown to reduce the risk of glaucoma progression. And the light trial has proven again and again that it can lead to a drop-free IOP control at 6 years in 70% of the patients. So that's quite good, and SLT can be repeated as well. Lastly, because of time constraints, I'm only going to speak about refractive surgery as my last point. And I know that myopia is a very prevalent refractive error, and especially in Singapore, where myopia is most prevalent in the world. And a lot of studies have been done in terms of reducing the progression of myopia by using drops, etc. However, not much has been published in literature about whether or not refractive surgery as a once-off procedure would be much more cost or carbon effective as compared to a lifetime wear of glasses and contact lenses for those who has established myopia, who have stable established myopia, more so in the 30s or the 40s, because we know that contact lens needs changing every day or a month for the rest of their lifetime, or glasses every 2 to 3 years. And for contact lenses, they're often not biodegradable, and they ended up in our waterways, flushed in the toilet, and then microplastics come back to our health because we consume them. So I think as clinicians, we do have a lot of scope in rethinking practical solutions for the future, and doing things for now and doing things for the future in terms of 20, 30 years later to minimize the impact of cost and carbon, and also to improve the quality of life for the patients, and delay their progression of their ocular condition in the longer term. Thank you so much.
Thank you, Dr. Wong, for covering so many considerations within the different subspecialties in such a short period of time. It's really inspiring to hear the extent of concern you're able to relate to the eye profession. Thank you very much. Let's welcome our next speaker, Dr. Radhika. Dr. Radhika is a UK consultant ophthalmic surgeon with 14 years of experience, holding a substantive NHS post at Royal Free London NHS Foundation Trust, an honorary consultant ophthalmology position at Moorfields Eye Hospital, NHS Trust, as well as private practice, and is a fellow of the World College of Refractive Surgery. She additionally founded and chairs the AECOS Green Working Group, an international sustainability group for eye care. She was named one of the top 10 rising stars in ophthalmology by the recent Ophthalmologist magazine. On top of this, she also poses a strong presence on social media as an eye profession advocate. Today, Dr. Radhika will touch on how NHS is going green, sharing a framework for local and international collaboration in sustainable eye care. Dr. Radhika, please.
Thank you so much. Wow, that's quite a welcome. I hope I live up to the hype. So you've already covered kind of what my background is, and I really loved the last talk as well, and the previous ones. Basically, I would say that my journey into sustainability was very much inspired by the Aravind Eye Care Centre or system, and by Venkatesh. So thank you so much. And it feels like a full circle moment to present alongside him as well. And I really loved Yee Ling Wong's mention about refractive surgery and how, it really is a very sustainable practice too. So let me just see if I can progress here. Yeah. So I'm going to mainly focus on the activity and work that we did as part of the AECOS Green Working Group, which I founded in 2022, pretty much around the time when I developed this sustainability session at AECOS in Europe, and invited Venkatesh and as well as David Chang and a few other people to present on sustainability. And of course, when you get off stage after doing a presentation, you say, okay, I'll see you next year. But actually, at that moment, I had this kind of light bulb moment when I said, you know what, I think we should actually do something about it. So our approach to sustainability is act locally and impact globally. And some of the work that I've been doing has been locally with the Greener Royal Free London Sustainability Network, and then you'll see how it works in the wider field as well. So we talked about this before, there's a lot of waste from phacoemulsification, from cataract surgery, from eye care, and the bottom right is basically the very small amount of waste produced by 5 cases in Aravind compared to all the horrible number of bags you see everywhere else. So what we did is we started to develop a team. We said, actually, in the end, you have to have one leader or a few leaders driving the change, but you do need support from your community. This is the most important slide, and actually this slide, since I spoke at Aravind a couple of years ago, I've actually expanded the slide because when I visited Aravind, I realized that there was a few things missing from my framework. If you take anything away from this talk, it's this framework to say that, we are so overwhelmed by the problem of sustainability or the problem of carbon footprint. And, what we end up doing is, we're so overwhelmed when we do nothing. And so I wanted to create a framework where we really engage all the stakeholders and try and figure out who are the stakeholders, who are the people we need to engage in order to make an impact in sustainability. And then how do you really pick what to work on? Because you can't work on everything all at once. And so I said, okay, for example, as part of ACOS, I can be the ACOS member, and that can be any hospital anywhere in the world with an eye unit. And every single eye unit in the world should have a sustainability warden, somebody who can hold that community or group accountable. You may then interact or interface, depending on if you're in an academic setting or in private practice, with a local sustainability champion or lead. After that, you need to figure out, okay, I need to engage the clinic staff, the theatre staff, and after Aravind, I realized how important it is to engage patients as well. And then you go down to the next level and you say, okay, well, who are we going to engage in terms of actually doing the projects? And though it's not sexy, we must look at waste management, and then as well as pharmacy and medicine optimization, and then actually pathway efficiency. And I'll leave that in the corner for now because that's a broader topic, but we can focus on these things. Really simple, but in the UK especially, I don't know if many people know, but there's a lot of red tape, as there is in most places. But getting something through the NHS, it's very tricky. And you know what? Rightly so, because I suppose you don't want to just push anything through without thinking about the risks and mitigating those risks. So we actually take every single project we do and we put it through a quality or financial improvement team, and we actually do a proper project and design it. So here's just an example of some of the people, basically you can literally label the people and say, okay, you're going to be the sustainability warden, and just kind of name the people, name them so you can start to engage with them as a team. So it's really important to connect with your local green initiative. Not all of us have Aravind or, the global planetary health care team at our doorstep. And so we need to just see what's actually out there already. You don't want to reinvent the wheel if it's already being done so locally. It also means you get more support in doing the changes that you want to, or making the changes you want to make. So we already talked about this, nominating a sustainability warden. And then you talk about how to design a project. And this is something that we don't talk about enough. So we need to really drill down and aim for a particular project. Think about the primary and secondary drivers and the change ideas. And I'll just give you a demonstration. You don't have to read all of this, but it's saying that just one of the projects we did, an example of a quality improvement project, was to change from single-dose units to multi-dose bottles of preservative-free medication. And we knew what it could do. We know it can reduce waste and plastic and medicine waste, but we didn't know how to do it. So we focused on, okay, what needs to change for this to happen? Well, we need to figure out what dropped, go into prescribing, go into training and education. And we looked at all the possible risks, all the things that the management team could come back to us and say, actually, you can't make this change because of X, Y, Z. And once you start mitigating that risk, then you start to realize, okay, yeah. And then you get to the point where you're presenting the plan, and then everyone's on board because there's really nothing wrong with the plan. So this was just an example. We got our medical optimization team, our pharmacy team, to send us a list of all the medications being used in the ophthalmology department at the time within Royal Free, and we kind of just focused on 8 medications. We said, okay, these do come in minims as preservative free. And actually now in the last few years, we have this special valved bottles, which can contain preservative free medication. And we assumed at the time, presumed that it would be some waste reduction. What I was not prepared for was how much waste reduction and how much cost saving. And so I actually myself physically went and got boxes of these single dose units from our pharmacy, got a very kind of accurate weighing machine, and we weighed these. And actually the difference between the weight of this and the weight of just a normal bottle was astounding. So it was going to be an 80% to 90% reduction in waste. And then I said, you know what, let's look at the cost difference. And I was then again astounded that the cost difference was such that we were saving money across the board, and sometimes even up to 75%. And actually many of these companies, they want to be a part of sustainability projects or, support a wider change that will actually drive the price even lower. These are just examples, and I haven't shown you exactly what it's been replaced with because it's not we're not focusing on the company here. We're focusing on the problem, the solution, and then afterwards you do something called fair procurement. And that's very important within the NHS. You can't just say that this company came up to me and gave me a good price and took me out for dinner, and therefore I'm going to be using this medication. It just cannot work like that. And so we say that, you know, every company is replaceable, but the thought process behind it is not. And so guess what? We changed this just locally in the North Central London area. And we found out that by making the changes in the community as well, which was a whole other sort of project that I worked with Moorfields and with the whole of the North Central London team across the board of Royal Free, we actually made changes that could save us between £300,000 and £500,000 per year. That's just with this one change. So that's when you realize actually we are making an impact. Some of the other projects that I'm going to quickly kind of run through is another one talking about how we must reuse, we must replace often, but if we can't, and in that moment something is broken, we should use single-use instruments that are recyclable with high-quality steel. And you don't just take the word of an instrument company, you actually go and visit the plant where they're recycling it and see how it actually happens. And we actually took our entire theatre team to visit the local plant to see how these instruments were being recycled. And now I don't ever have to ask, are you recycling that? The team in the theatre knows. The third thing was looking at bin layouts within our I unit. So we actually got the waste management team to come and map it all out. And my thinking was that we should create and this is in process still, to create a QR code that is a live QR code that shows us what things can and can't be recycled in your particular practice. Because as you know, different places and different plants are able to recycle different things. And what I realized is that now we're using a lot of obviously minims in our clinics, but also, you know, these single-use Goldman throwaways for checking pressure just because of COVID and everything else that happened before. And we do need to really, you know, revert back to reusing these things. But in places that you can't, you know, we tried to explore, can we recycle it? And we were told point blank that if you put this in a recycling bin, it's not going to get recycled, because we saw in the sorting machines, they were just falling through the cracks. So these are things that we need to think about and come up with solutions for. Most recently presented on changing to reusable hats. I mean, some places in the world, you know, including India, they already do this. But in the UK, you can imagine we were using, you know, more than 7,000 disposable caps a year. Though the cost is not much, you can see the carbon emission is lower. And actually, you know, patients appreciate it, the staff appreciates it, they have their names on them, so the patients know who they're talking to, and now we have ones with the Green Working Group logo as well. So I think we've had quite a few achievements globally, but that wasn't the point. The point was to act locally and then impact globally. We have published internationally. In fact, one of the things we picked up on was the information for use leaflets, and how it's such a waste. And we actually named and shamed some companies and actually published in the Journal of Cataract Refractive Surgery. And I talk a lot about it now on social media, now that I have my own proof of my own work that we can save money. But, you know, it wasn't just in the eye industry that we were making changes. We actually managed to, one of our colleagues actually then went on and helped the gynecology team, and actually they looked at their contraceptive leaflets too. So we're, you know, not just impacting our own eye unit changes. And so my real takeaway is, you know, get a sustainability warden and tell us, connect with your local green initiative, try and find a baseline, but don't stress about figuring out the life cycle of an instrument or life cycle of anything. Just weigh it, see the waste, make the change, remeasure it, and you'll find that these small low-hanging fruit, you know, actually make a big impact. And the last thing we did was design a logo, which was created by Dr. Kilduff, and you know, we already kind of went through this, and you know, in fact, we also got invited to be part of iSustain, and we were really grateful that we have actually a space on their website. And my plan long term, and I hope that maybe all of you will join me in this vision, is to actually have a Miro board, and I've actually created one where everyone all over the world who is in eye care and sustainability actually puts their ideas and what they're doing on there, and then you can literally, you know, zoom in and see, oh, I wonder what Radhika is doing, or I wonder what iSustain is doing, or I wonder what Venkatesh is doing. And so we're not kind of we're learning from each other, collaborating truly, and there's a lot of things that we can do going forward. started. So, you know, now we're moving on to doing more social media stuff, and I will be using my influencer status to hopefully spread the word. So thank you very much for listening. And just to summarize again, let's all act locally and impact globally. Thank you.
Thank you, Dr. Thank you, Dr. Radhika. Hope we're all signing up for the Miro board now. Oh, sorry. All right. So thank you for sharing the evidence-based honest takes on recycling and the framework on steps we can take to actually get there as a group through identifying relevant stakeholders, because we can't do it just by our own profession alone. So keep the questions coming for the audience. Keep it coming in the Q&A tab, and we'll get to you shortly in the Q&A that's coming up soon. Finally, we'll introduce our final speaker of this session, Dr. Rahat. Dr. Rahat is a senior consultant ophthalmologist at Singapore National Eye Centre. He's currently co-head of the Sustainability Committee and is passionate about environmental causes. He is particularly interested in changes that physicians can make to improve their carbon footprint in their day-to-day practice. Let's welcome Dr. Rahat to share a reflection on SNEC's sustainability team's journey, challenges, and progress. His topic is titled Embedding Sustainability in Institutional Practice, Lessons from SNEC. Dr. Rahat, please.
Thanks, Ling Yan. I hope you can hear me okay, because I know I was having some problems earlier with my internet connection.
Yes, we can hear you fine.
Thank you, Dr. Rahat. That's the reason. I tell you, I'm so impressed by the previous three speakers, and I've learned so much, and it's really enheartening to see what people are doing around the world and how we can learn from each other. Right, so I'm going to just start by showing you how our journey started, really, in fact, earlier than 2021. In fact, we had a very even more informal committee with just a few of us. And over the years, we've been getting more and more people involved, and I'm the co-chair now of this Green Committee. And as you can see here, we've expanded to more than 12 members now. And, you know, this really is, it's actually quite physician-light. There's lots of nurses, lots of admin staff, optometrists as well. And so we've really tried to build up the pool of people who are interested in this area in SNEC. So the title of this talk was about how we embed sustainability practices in eye care. And this slide, I think, really shows what, in summary of how we've tried to do this. And, you know, this is sometimes very overwhelming when we think how much we need to do and also how much we can do. You know, there's not a day hardly where I walk around and I say, oh, we could change this, and, you know, we could change that. So how do we do this in a sort of logical way so that it's embedded into our day-to-day practice? And what we did is we set up these sort of 6 areas with leaders and members in each area to look at the particular work group that needs to be addressed. So, for example, reducing waste and water in the OT, and recycling waste in the OT, and reducing waste overall, electricity and water, and also culture as well. So this is how we've tried to do this, and we sort of, each team leader will engage with their members, and when we meet up, we ask for little updates of what you're doing, and people come up with other ideas. So in this way, we've tried to embed this culture of sustainability in our day-to-day practice. So I'm just going to, the next slides are really just showing you what we've done, and I kind of feel a little bit embarrassed when I hear what's been done elsewhere, particularly in Aravind. But, you know, we need to start somewhere, and I think it's small steps, and we're going to get there. So just a few examples of what we've been doing is we're looking at using OT combined surgery packs, and that can reduce waste by about 50%. And reducing the use of the disposable medical sponge. We're still using this in some cases of before the first case in cataract surgery, even though the evidence shows that actually you probably don't need to do it unless you have some visible dirt underneath your fingernails, and even then you can use a small pick. But, you know, old practices die hard, and on my last slide I'm going to show you about some of the challenges we faced in this, but these are some of the things that we've done in the operating theatre. We've concentrated on the operating theatre quite a lot because as eye professionals, that's a big part of our working week. And as an eye surgeon myself, it's something that I see every week. And, you know, we can, the operating theatre nurses as well will often come up with ideas on how we can change things. So here's another one on ophthalmic packaging. And we even do things like we have a little pantry, and before we used to have lots of disposable plastic cutlery, etc. And now it's all changed. So everyone has to bring their own mug, or there are some commonly shared mugs, and we reuse and clean our own utensils. So we have these meetings, and sort of when we have our regular meetings, again, it was very much disposables were used, but now that whole culture has changed, and we again bring our own mugs, or we have cutlery and used cups that are returned to a tray and is cleaned later. We're big on now on paperless forms, and we're about, I would say, about halfway in our journey of going almost completely paperless, and there's still some work to be done on that. But as much as possible now, particularly when new initiatives are coming on board, we try and make sure that the information is either displayed or consent forms, for example, we're moving towards digital now. But you know, SNEC is part of Sing Health, which is a bigger group, and so we do need to be compliant with our parent body protocols on that as well. So it's not like we can just decide, oh, we're just going to do away with paper. We have to make sure that what we do is safe and appropriate for what we're trying to achieve. So we have what's called Orchid Thai. So it's a sort of a cafe on site, and it's an independent organization, of course, but we spoke with them about whether they could try and help to reduce some of their waste, and they've been very helpful with that, actually. And even in the new tenancy agreement they signed with us, they did incorporate some more reusable items, as you can see there as well, and also encouraging the use of vegetarian food, both from a health perspective and from a general positive contribution to climate change in reducing meat consumption. Yeah, our pharmacy team also got involved, and they started this initiative where instead of little plastic bags, which you can see here, which were traditionally given to patients to carry away their medicines, they encouraged to bring their own bag, and they can the plastic bags and put them in a or dispose of their plastic bags in an appropriate way. And we're quite big on our recycling in terms of putting out our bins here. So we have these 5 bin bags, and here this recycle thing scattered throughout the centre. And more we're finding that the general waste, the trash option is not going to be available in some areas, and even in our office areas we've stopped the use of a general bin, and everyone has to use the recycle ones. One of our colleagues, Dr. Leanne, she started this initiative where she recycled eye drop bottles. So after a patient has finished their drops, they can drop them into this bin, and those are recycled and repurposed, and she's really made some very good progress on that. In terms of segregation of our waste in the operating theatre as well, our nurses have been very proactive in that, and so there's bins here which is very clearly labelled which should go into which bin. I must say I always have to keep looking at these to make sure I get it in the right place. This was really driven by them, and they really pushed the surgeons particularly to use the right bin. In terms of the cassette casing in phaco, they put that specifically, and they found that these casings can now be recycled, and that was something that's wasn't being done before, and it's been found to be safe from an infection control point of view. We've also looked at our water efficiency and reduced our tap flow rates, as well as something as even as straightforward as carpet shampooing. We've tried to make sure it's more sustainable. Similarly with our lights and our electrical appliances, which we're trying to reduce any excessive waste. Desflurane, this is we've managed to reduce significantly the use of desodorizing, which is particularly bad in terms of carbon emissions, but we still got some work to do on that, and we're working with our anaesthetist colleagues as well. And we've also installed a couple of EV chargers in our car park. In terms of the cultural change, we've also set up a recycling corner on one of our staff levels, level 4 in National Eye Centre, where staff is encouraged to bring their old clothes and any objects that could be reused by people, and also for recycling as well. And we have recycling boxes as well. And so that's really just trying to show staff that you can make a contribution from your personal life as well, and you can help out others as well who might need some of the items that you no longer need. I've already spoken a little bit about this, about the reuse bag corner at pharmacy. So again, pharmacy's quite keen to support this and are really helping us to drive this. Bring your own utensils, including these food containers as well as cutlery, and that's all staff members are encouraged to do that, and we in fact have distributed these for free to staff members so that they can bring their own in future. There's also signage for the patients as well as the staff to try and make sure that no more water is wasted, or as little waste as possible. And we have these direct messages which are sent out by emails periodically, showing some of the initiatives that we're doing, giving people ideas like carpooling, e-red packets. This is for Chinese New Year, and in general, increasing awareness of environmental issues. These are some things we have in plan. I'm not going to go through these, obviously, but we've got a plan of how to do these things. And because we now have quite a big committee, we're hopeful that we can start some of these things. And in fact, listening to my previous 3 speakers, I'm sure there's even more that we can do. Okay, so I'll skip these 2 slides. So I'm just going to finish off with this slide, which was because the subtitle for this talk was about lessons learned in our journey, and perhaps some of the challenges that we faced. So I would probably reduce it to 3 particular areas, which I think are some of the lessons learned and some of the challenges, which is the first one, I guess, would be obtaining consensus in some of the changes that we wanted to introduce. And what I mean by that is, you know, we're as physicians, we're always very concerned about safety, rightly so. And we are concerned that any changes that we do which are different to how we've done things before, which have been shown to be safe, is that going to be a compromise to the safety? And there's this concept of perceived risk, which I'm sure many of you have heard already, that there is this thought that if we do things differently, are we going to make things worse? And what is the evidence for that? Because often it's found that there isn't much evidence. And I know some of the papers that were presented earlier today are good evidence to show that the changes that we want to do are safe. But about persuading our staff and our patients to go ahead with these things, I think has been a particular challenge. Whether we do consensus or top-down approach is something that's, you know, perhaps something in between, but you've got to be very careful about top-down approaches, because it's very easy to put people off any changes you want to make. On the other hand, consensus building is very difficult and time-consuming, and sometimes not even possible. So that's one challenge. I think the communication style is something I think is an important lesson learned. If you're trying to get people to change their behavior, how you communicate that is very important. And ideally, the cultural change needs to come first. And we also need to understand that there's often quite a range of opinions amongst our staff, particularly as to how big an issue this is. Of course, some people are very convinced, but other people are less convinced. Or I would say that they feel that some of the changes that we are suggesting are just too small fry. It's not worth the effort, which is understandable, actually. But you know, we do need to think about small changes and the large effects that can have. So that's something I think we need to be very careful about, is how we communicate that message to our staff and to our patients as well. And lastly, it was something that was already being touched upon, is about procurement of instruments and sets. And often these instruments are procured in sort of 2-year contracts. So even if you wanted to change things, you can't do it until that procurement time is finished. And we need to really engage with industry as to how to, what do we want, and then can they match what we want? And we shouldn't shy away from breaking previous partnerships if we feel that actually that's not really fulfilling what we want. So I'll end it there. Yeah, thank you very much for listening.
Thank you, Dr. Rahat. Hopefully with this sharing from different backgrounds and different levels of eye-related care, we can be more affirmed about what we are doing in terms of sustainability. So thank you for the honest sharing on sustainability at the institutional level that involves other healthcare professions as well. It has been insightful sharing our efforts of sustainability at different levels of eye care internationally as well. I'd like to take a minute to thank all our speakers for sharing their honest experience and struggles in this new topic of sustainability relating to planetary health. Today's conversation has inspired me to keep asking, where can I start? And to keep these conversations running with various people in hope to spark a change somewhere down the line. And I hope you're with me too. As we pave a new path in this unknown together, there's confidence in strength as we garner more advocates for the future from here on, even beyond our profession. So now we'll move on to the Q&A section. So let's get the conversations going. Muskaan?
Yeah. Thank you so much once again to all the speakers for these incredibly rich and insightful presentations. It is great to learn from all of you, and also the real world case studies that you shared with us today. So Lingan and I will be moderating the Q&A segment, and we'll begin with a few questions that we have from our side for all the speakers after listening to your presentations. And then we will take questions from the audience. In the meanwhile, please feel free to send in your questions through the Q&A box at any time for all our speakers. And just to open our conversation, I think this question is for everyone on the panel today. I would love to explore the internal side of the sustainability journey for you all. So I think sustainability work usually begins with a spark, a moment when you realize that something in eye care had to change. So could each of you share what that moment was for you and how it shaped your approach to integrating sustainability into your clinical or institutional practice? Maybe we can start with Dr. Venkatesh, then Dr. Yee Ling, Dr. Radhika, and finally Dr. Rahat. Thank you.
I'll come to the end.
Oh,
I'll come last because the story is.
Whoever wants to go first, please go ahead.
Okay, I'll go first. I think my journey was quite incidental. I never thought about sustainability when I was a young ophthalmologist training in Manchester, but I was looking for research, and one of the professors, Professor Tariq Aslam in Manchester, actually says that, oh, do you want to publish a paper on ophthalmology going greener or something like that? So I was like, okay, I'll take that opportunity to write a paper. It's free publication, so why not? So I just wrote a paper, and then one day, I think I got an email from David Chang who says, oh, it's such a good paper. Do you want to be part of iSustain? And like, yeah. So that was how it started, and more publications started, expanded then.
Great. Dr. Radhika, do you want to go next?
Yeah, so sorry, turns out I had my video off, so you guys missed out on all my hand gestures through the talk, so maybe it was a good thing. So I kind of touched on it already, to be honest, how I was really inspired when I organized the first sort of ACOS sustainability session in 2022. And, I was on stage and I had Dr. Venkatesh and Dr. Chang and all these people kind of talking about this work that they're doing. And I was so inspired when I came off the stage. I was being interviewed on iTube. And as I was talking, they were like, so what are you going to do? And I was like, I am going to do something actually. So, and that's how it all started. And I've been, as I said, now it's a full circle moment, presenting next to Dr. Venkatesh. But in between, I was invited when I went to India to actually come and visit Aravind, and it was incredible. I really recommend it to anyone to really go and immerse yourself in what true sustainable care looks like.
Absolutely.
Yeah, I'll tell you. So for me, it was about wastage really. So in my clinics, we had these printers, or we'd print out forms and consent forms, and no, it was prescriptions forms. And I just noticed that although we had changed to electronic, we were still printing out these forms. So I sort of questioned, why are we doing this? And then I sort of look around, and everywhere I turned, I could see there's so much wastage going on. I, of course, was interested in sustainability before that anyway, but it really showed me how much changes we could do in our practice, and so that's how I got started. And then, as Radhika was saying, I heard what was going on in Aravind, which made me think, wow, we have got so much that we can learn from these places. So yeah, that's my story.
Thank you for
Okay.
that, Dr. Rahat. Yes, go ahead, Dr. Venkatesh.
So my journey started somewhere in 2016-17 when I had a Fulbright fellow, Casey Thale, who come and work with me because I accidentally met her in one of the RO meetings, and she said, I'm an environmental engineer. I said, what are you doing in an RO session? She said, I work on waste. And she showed me a couple of papers on hysterectomy waste and all that. And I said, I'm from Arvind. And she said, I'm looking for a partner in Arvind. This all happened on a lunch table. And then she got a Fulbright fellowship to come. And then we did that waste study comparing what happens between Arvind and the Western world, where we found what we do is just 5% of what happens there with the same kind of results and all these things. But what we realized is, that is the point when people were really interested in evidences. So we are doing nothing new towards sustainability. What we are practicing centered around patient care, now we are trying to bring in more and more evidences so that the world is going to say, okay, this is also a way of doing, So that is where the journey started. But if you say sustainability, Arvind has been practicing from the day one, because it has been always centered around patient. We don't want patients to come to the base hospital. So we started outreach. And then we started vision centers, because our founder was very clear. He said, you have to reach the unreached. Then we realized by reaching the unreached, you are going as a team so that several people need not come to the base hospital. So these are simple things, where anybody, I can tell you, if you center your care around patients, you will definitely be friendly to the planet, and you will make profit like what the other publication said, either sequential bilateral or what Dr. Radhika was saying, how much revenue by reducing a drop or reducing a plastic. So automatically this triple P will happen if you center your care around the patients.
Absolutely. Thank you so much for sharing that. I think it's so powerful to hear how these personal experiences really drove systemic change within your own practice and institutes, right? And with that, I'll hand over to Lingyan for the next question. I'm sure you have a lot of pressing questions, Lingyan.
Yes, actually, I probably would then prioritize the questions that's come into our Q&A box. So I think it's pretty similar genre. So they're more asking on how to take a first step towards sustainable ophthalmology, and how do we involve patients in this sustainable vision. So I feel like, Arvind again is quite the center of the core of inspiration from today's talk. So maybe we could start off with Dr. Venkatesh, and then the rest of the doctors can just chip in.
I think the best place to start will be in your operating room, where you have all these complex waste. But when you think it's complex, it's going to be complex. But if you can break it down at source, if you can separate your paper from plastics, if you can separate your real biomedical waste, which touches the eye, or the fluids, or your wiper, which you clean the eye, from the consumable waste, where you're just opening those packets and discarding. If you start there, you will realize that, like what I'm giving data, it's 85-15%, 85 non-biomedical, 15 is biomedical. You can even start 50-50 somewhere. Now, if you can start recycling those things, Dr. Rahat beautifully said how they are now using those phaco-cassettes and the tubings, which are most plastics, and they are not contaminated. No, you can recycle that. But many of the time it was going into biomedical waste. Now we all realize that you don't have to use one cassette for every patient. you can continuously use the cassette wherever possible. And now people like David Chang are working with industry to make sure you have a click fee than going for changing the cassette. So there is a win-win for both industry and the consumer who are the surgeons. But I think you can start in the operating room.
Yeah, shall I just add something? So I think we also have to recognize that we're not experts in this field, and what we often have to take quite a broad view in terms of what's going to be the most impactful thing that we can do. So I'll give you an example. So I read a book a year or two ago now, actually, which said one of the most impactful things we can do is reduce our meat consumption, because that has a big impact, beef, particularly in lamb. So so sometimes you think you're doing something, but actually there's something else that you could actually do that would be more impactful. So that would be my thoughts on that, is that we have to really listen to the experts in this field and get their input as well as to what sort of changes that we should be focusing on.
Yeah, probably a good time to also step in that, because Dr. Renzo's in this on the whole planetary health, he has a whole YouTube series on like different parts of how we can actually be a little bit more sustainable. So if there's any topic that's particularly of interest to anybody, you can feel free to log into YouTube, have a look at Dr. Renzo's whole log of collection of all this relevant series. I think I also like to just add in one more question, if you all don't mind. My question is, how does climate crisis mean to you as a healthcare professional? Like, to all the speakers, if any of you want to take this question, what does climate crisis mean to you as a healthcare professional?
Maybe I'll go.
Okay,
go on.
Very clear message in Lancet, right? Radhika, sometime back, it said that is a threat and there is an opportunity for people in healthcare. So one of the magazines were titled as threat and another magazine titled as opportunity. I think because we all know, because we are not experts to say how much the climate change is changing the world, how much is melting and things like that. But we tend to see the climate change. You have unusual, at least here we are seeing unusual rains and unusual climate change things which are really now relevant to us, which is touching us in our daily lives. So there is an opportunity for us. And where is the opportunity is, again, how do you really look at those opportunities is important. Even many of the small things which you practice are also opportunities. So there is a beautiful saying that only few water droplets can make an ocean. In Tamil, there is a saying. So somewhere you have to start. It can be changing your food or changing your boxes or changing your things, but people have to change.
Yeah, absolutely. Yeah, I was going to say that's what my whole talk was, that we're so overwhelmed with climate crisis that we just get scared and then we do nothing because we're like, oh, it's all too much. And so just starting. So if anybody really wants to start, you could literally contact any of the iSustain or ACOS Green Working Group. I've sent my email across to you because somebody asked about access to the Miro board, and I think the best way to do would be to be a sustainability warden and then have access into it. And then yeah, just literally pick one thing from something you've heard today, or one thing from looking at just go and for the next 1 week, just walk around your environment and don't think that, oh, I'm just a medical student or I'm just one doctor, what change can I make? Just go around thinking, okay, let's see, because guess what? Everybody thinks it's the other person. But actually, you are these people, you are that guy, you are that woman that can make the change. And so I think just having that belief in yourself and then just, measure, change, and remeasure.
Absolutely. Thank you so much for those powerful reflections. I think this is one question that I just saw in the Q&A box, which is quite relevant. And I think we also covered some bits of it in your presentations, is how do we involve patients in this sustainability vision? I think this is a very important point. Would someone like to cover this?
Radhika can tell what she saw in Pondicherry, because that was part of my last few slides, where I had to cut short. But Radhika is really And as I see
Yeah,
that
so
there's a tour
I
going
mean,
on now. There's an evening tour
oh,
going.
it's a no, you know, just touring around Aravind, that's when I changed my stakeholder, you know, sort of a PowerPoint slide, because I was like, actually, I'm missing one of the key stakeholders, which is the patient. And I would say that we're not, as ACOS Green Working Group, there yet, but Aravind is way ahead. You know, it starts with, you know, measuring the patient's route into the hospital. How are they traveling in? What route they're taking? How, you know, what information is on the boards, you know, for the patients to learn from. There was a lot of patient integration work that I, to be honest, hadn't really come across. We all do it in little smatterings, you know, across NHS, but this was like intentional, well thought out and constructed. So if we could just take one of those changes, you know, even just them showing the video in the waiting room to the patient of what the surgery is going to be like. And actually, I remember very well that there was actually a questionnaire at the end for the patient to answer to see if they actually understood what it was, because then that's less chair time with the doctor. Therefore, more patients can be seen. You know, all these kind of interesting ways of doing it. And I think they even have like a board where patients put their feedback, and then that's taken on board, and patients feel engaged in it. And then there's plenty of, you know, when you do the tour around, there's actually like sort of areas where it's like marked, like this is what we're doing for sustainability. So patients are literally walking around, they're waiting for their relatives. They can read about sustainability as well. So I would say that if we made even one of those changes that integrate patients, you know, we can make a huge difference. But I think this area in particular is something that we're going to be building on over the next year. I literally at 2 a.m. this morning had a meeting with the American you know, the American sort of team, the ACOS Green Working Groups. It's just been expanded into America. So we spoke to the president of America there. I did say that we won't be scheduling a timing such as 2 a.m. anymore. We're going to do it a few hours before. But, you know, we discussed this, and it's about collaboration. And so I think continue to collaborate and then think of these amazing ideas, because now you've asked this question about patients, this person in the audience, it's already getting me thinking about the next steps, and now, you know, remembering again what was happening at Aravind. So yeah.
Right. Thank you for sharing those insights, Dr. Radhika. Go ahead, Ling.
Sorry, just wanted to ask if Dr. Yee Ling or Dr. Rahat had anything more to add for this.
I think I'll just echo what they've already mentioned. I think Dr. Venkatesh mentioned that whatever is good for the patient is actually good for the environment. So improving the patient's quality of life by saving one trip, one travel, making life easier for them, making things easier, information easier to deliver to the patients, making stuff more efficient for the patient would actually benefit the environment in some way. So if you think about patient quality of life, patient care, how to improve them, you're actually also at the same time improving the patient's, the environment at the same time.
Yeah, nothing more to add really, Muskaan, from what's already been said. Thanks.
I think engaging them, no, is a key. No, that's where. See, one thing is engaging them in all these procedures and investigations where you save all those time. The second part is, you know, really telling them what you're doing, so that even if they are going to carry that message, they're going to practice it. No, of course, for example, plastics. Now we try to avoid all those carry bags which comes from outside where they buy packets. So what we do is we encourage by giving them the tiffin boxes here. So you can pay 500 rupees, Indian rupees, hire the box for the period of stay. For example, some corneal ulcer or maybe an optic neuritis, needing a methylprednisolone, staying for 4-5 days. What they do is they go outside, they buy a lot of packets, and then they come inside. So we give them tiffin boxes now with 2 plates, with all the necessary utensils. And you return that 500 rupees once you return the tiffin box. In fact, that kit is more than that. It was 800 rupees. I said, fine. No, we can't collect 1,000. No, that's a big amount. So small things like this. Now we have every hour there is an announcement saying that how much solar we generate, how much water we recycle, and know how much carbon footprint we reduce. We have signboards everywhere saying that. Even sometimes somebody puts a paper or a plastic or something. So we have a big acrylic box now where it's trying to just shame them also. No, we drop it there and say, this is not dustbin. This is something which you dropped on the floor. We have cleared it for you. It's kind of bringing that accountability in the customers who come to your place, And we also, we never see them as patients, At least here we see them as customers. No, they are coming for a care. Maybe laser, glasses, cataract surgery. Many of them don't have real disease there. So if you keep engaging with them, they also learn from this process. And many of them have taken addresses from us, contacts from us to put solar in their home, to use this water recycling plant, which we have in their hotels, in their industries. So it's been a kind of, where you bring this orientation and then they bring more people into this. And then they also tend to learn from what you're doing.
Yeah. Thank you for sharing those insights, Dr. Venkatesh. And I think in the interest of time, we can start wrapping up our discussions. And before we close, could I invite each of you to share one sentence on what you believe is the most urgent next step for sustainable ophthalmology? I know, a difficult one, but would love to hear your perspective before we close this session.
You use the opportunity, which is in front of you. There are several ideas, especially Rahat gave several ideas, how you can practice. So use those opportunities, and then you will definitely bring some kind of a sustainable practice.
For me, I would say it's engage with the resources that are already available, like iSustain or something, as the most important next step that you could take, because that will really open up the world of like-minded thinkers and give you some guidance as to what to do in your particular institution, in your particular environment.
Absolutely. Dr. Radhika?
No, I was just going to say, please feel free to contact me, and I will try and, be a sort of a sustainability consultant, I guess, and try and give you some tips. And I'm more than happy to do that. And I've done that for quite a few people, and I think, yeah, look forward to collaborating with you all.
And I think for me, one of the most important things to know of or be conscious about is that there's actually quite a fine line between infection control and sustainability, that we don't want to be too afraid of certain things that we don't recycle some stuff. For example, when I was a ophthalmology registrar, I tried to recycle a plastic that's actually just touched the patient's hand, and they say, no, you can't recycle this because it's touched the patient. So we need to have evidence that actually we have to be practical, and there are things that we can recycle, and there are things that it's not infection control, for example, gonio tips and other things that they're saying that, oh, there's a risk of CJD, but is there really? So it's really important for us to put the evidence out there that actually don't be too afraid about infections, because you're actually human and you're touching everywhere. Yeah, so that I guess it's important to put the evidence out there.
Absolutely. Thank you for those closing insights. And once again, thank you so much to all our speakers for your generosity and leadership, and to everyone who joined us today. This conversation really showed us that sustainable ophthalmology is not only possible, it's already happening across the world, driven by, of course, passionate clinicians, researchers, advocates. And on behalf of the Planetary Health Initiative at SDGHI and also the Singapore National Eye Center, thank you again for being here. We look forward to seeing you in future sessions, and have a wonderful evening, everyone.
Thank you.